Hi everyone, I'm Vicky. I'm the Maternal Medicine Fellow working in MFM unit in Hospital Tunku Aziza. Today, our discussion will be on gestational diabetes mellitus. I believe this is a very familiar topic to most of us, especially the clinicians working in primary care. The main point we would like to discuss would be controversies surrounding gestational diabetes, especially in screening and early versus late diagnosis. The content of our discussion today includes introduction to GDM, the implications of GDM on maternal and fetal outcome, the controversies surrounding this topic, what does the evidence say, and we wrapped up the discussion with a few points to ponder. Gestational diabetes is traditionally diagnosed after 24 weeks. It occurs due to profound insulin resistance in late second and third trimester. Early screening is to exclude pre-existing diabetes. As we know, pre-existing diabetes and GDM both have significant implications on maternal and fetal health. Let's look at the pathophysiology of diabetes in pregnancy. In normal pregnancy, there is increased blood glucose concentration and reduced peripheral insulin sensitivity. And this stimulates the beta cells in pancreas and leads to compensatory hyperplasia or hypertrophy of beta cells. After pregnancy, everything returns to normal. Whereas in patients with gestational diabetes, the high blood glucose concentration and reduced peripheral insulin sensitivity does not lead to adequate compensation by the beta cells. So there is inadequate compensation of the beta cells in the pancreas. And after delivery, this inadequate compensatory mechanism remains in the pancreas. The beta cells remains impaired and the blood glucose concentration may return to normal or may remain slightly higher. The peripheral insulin sensitivity remains impaired throughout. Therefore, patients with gestational diabetes has increased risk of developing diabetes later on in their life. This beta cell dysfunction and hyperglycemia in pancreas may lead to effects in multiple organs, which include in the brain. It leads to increased appetite. Patient tends to eat more, but there is reduced energy expenditure. In adipose tissue, insulin resistance leads to reduced expandability, increased lipolysis, and it increased free fatty acids as well as a consequence to it. There is increased leptin, reduced adiponectin, and increased pro-inflammatory cytokines leading to higher risk of developing infection. In the liver, insulin resistance leads to increased gluconeogenesis and ectopic fat deposition. And most importantly, in the placenta, increased insulin resistance leads to increased placental leptin, increased pro-inflammatory cytokines. There is increased placental transport and leading to fetal macrosomia as well. Hyperglycemia, hyperinsulinemia, increased inflammation and oxidative stress in intrauterine environment leads to a 3 to 5% of development of anatomical malformations for the fetus. There is 30 to 40% of hypothalamic dysfunction and development of obesity in childhood and early adulthood. There is increased incidence of delayed neurocognitive development, neuropsychiatric disorders, neurodegenerative diseases, and anxiety in early adulthood. There are multiple studies which have been conducted to look into the effect of GDM in pregnancy. And nonetheless, we have one of the famous paper here by the HAPO study group looking into hyperglycemia and adverse pregnancy outcome. And they concluded with mother with a high glucose in their blood, hyperglycemia for mother leads to increased incidence of birth weight more than 90th percentile for the baby. There is also increased incidence of primary caesarean section, and more importantly, we have more babies with clinical neonatal hypoglycemia. and more babies with cord blood serum C-peptide of more than 90th centile. Other groups, such as the Australian Carbohydrate Intolerance Study in Pregnant Women group, look into effect of treatment of GDM on pregnancy outcome, and they concluded treatment of GDM reduces serious perinatal morbidity and may also improve the woman's health-related quality of life. This is another paper which looked into treatment of mild gestational diabetes, and they concluded although treatment of mild GDM may not have significantly reduced the incidence of stillbirth or perinatal death, but it did reduce the risk of fetal overgrowth, shoulder dystocia, caesarean delivery, and hypertensive disorder. Now, what are the controversies surrounding GDM? First, the timing to screen and to diagnose. Should we do it early or late? Should we do it universal screening or risk-based screening? Which approach to use, 1 step or 2 steps? And what are the cutoff level that we should employ when we diagnose patient with GDM? This is a table that are summarized according to different international bodies and their approach. The International Association of Diabetes in Pregnancy Study Group, WHO and FIGO, adopted universal screening with 2 hours 75 gram OGTT at 24 to 28 weeks, and the cutoff use is fasting more than 5.1 to 6.9, 1 hour more than 10, and 2 hours more than 8.5 to 11. Meaning if a patient has fasting more than 7 or 2 hours more than 11, then they will be diagnosed as diabetes instead of GDM. What about in the US? The United States Preventive and Strategy Task Force employed universal screening, a glucose challenge test instead. This is a 2-step test and to be done at 24 to 28 weeks to diagnose GDM. And the level used here is fasting more than 5.3, 1 hour more than 10.6, 2 hours more than 9.2, and 3 hours more than 7.8. What does the NICE guideline say? NICE approach, they adopt risk-based screening with 2 hours 75 gram OGTT. Patients with history of GDM will be screened at 16 to 18 weeks, and all other risk factors will be screened at 24 to 28 weeks. Cutoff use is fasting more than 5.6 and 2 hours more than 7.8. What about our local protocol? The Ministry of Health adopt risk-based screening. We have a list of risk factors to be looked into by our primary care clinicians. We use the 2 hour 75 gram OGTT. We screen our patients as early as possible, sometimes even at booking or at 7 to 8 weeks. And the test would be repeated at 24 to 28 weeks if the first screening is negative. The cutoff being used for both screening tests is fasting more than 5.8 and 2 hours more than 7.8. What is the rationale for early screening? Early screening enables us to identify pre-existing diabetes in pregnancy. We all know that overt diabetes has significant increased risk of adverse outcome for both mother and fetus. And pre-existing diabetes leads to vascular dysfunction and end organ damage. By diagnosing pre-existing diabetes early enough in pregnancy, it allows us to initiate treatment earlier and also to put some prophylaxis in place, such as preeclampsia prophylaxis by starting aspirin, later on with calcium and vitamin D. It also allows us to risk stratify and to identify which population will require a normally scan to detect congenital malformation. Studies have shown that accelerated fetal growth may have already started prior to diagnosis of GDM at 24 weeks. And in fact, fetal adiposity may have occurred by 26 to 27 weeks. Therefore, people think that screening and diagnosing diabetes after 24 to 25 weeks may be too late. There is long-term effect on future health of the offspring, not just the mother, but the offspring. There is higher risk of development of diabetes and cardiovascular diseases. So theoretically, there's definitely benefit of early treatment of diabetes to reduce risk of adverse pregnancy outcome and its long-term implications on both the mother and her offspring. But what approach do we adopt for early screening, and what cutoff and which cutoff should be employed? This is a table that I summarized from some of the studies. In first trimester, if we use fasting blood sugar, then the cutoff should be more than 7. We should employ a similar cutoff for non-pregnant populations, because we know in first trimester, the profound changes, the physiological changes in pregnancy has not reached its peak yet. And we know that the non-pregnant population, their fasting blood sugar cutoff is more than 7 millimole per liter to be diagnosed as diabetes. HbA1c more than 6.5%, random blood sugar more than 11, and if we are performing an OGTT in first trimester, level to use would be fasting more than 7 and 2 hours more than 11. What about at 24 weeks? As we discussed earlier, fasting should be more than 5.1. Should we use HbA1c to diagnose or to screen GDM in pregnancy? Now, HbA1c needs to have a trimester-specific range, and we'll discuss more into HbA1c and screening of GDM. Random blood sugar more than 11, OGTT at 24 weeks. We use a fasting more than 5.1, 1 hour more than 10, and 2 hours more than 7.8. Let's have a look at the remarks that I put here. Fasting blood sugar continues to fall throughout pregnancy, meaning in first trimester, if we have a patient with fasting blood sugar of 5.4, do we diagnose the patient as GDM? If we were to carry out another test at 24, 25 weeks for the same patient, it will not be surprising to get a fasting blood sugar by then of less than 5.1. So, should we diagnose the patient with GDM in the first trimester itself if their level is below 7 but more than 5.1? Number 2, HbA1c. Certain countries actually start using HbA1c of 5.7% instead of 6.5% as cutoff for GDM. Why so? We'll talk about this with evidence later on in other slides. Cutoff used for OGTT is actually adopted from the HAPO studies. And we know that the HAPO study was carried out using a cohort of pregnant lady above 24 weeks. Therefore, the cutoff used before 24 weeks is not valid. Elevated fasting plasma glucose, OGTT, and HbA1c below threshold level for overt DM is a strong predictor of development of GDM later on in pregnancy. Now let's talk about HbA1c as I promised earlier. HbA1c of more than 6.5% according to the current guideline may have missed more than 50% of cases of diabetes. In fact, in the New Zealand, study has shown that HbA1c more than 5.9% itself predicts pre-existing diabetes and adverse pregnancy outcome. In Switzerland, all women with HbA1c more than 6% develop GDM later in pregnancy, compared to women with HbA1c less than 4.5%. It reflects early pathophysiology of derangement of beta cell function, and it is the glucose disposal that is characteristic of GDM. Therefore, HbA1c may be a useful tool for early restratification of GDM instead of screening and diagnosis. We also know that HbA1c is affected by conditions which alter the lifespan of red blood cells. Pregnant women exhibit altered red blood cells kinetic, hemodilution, and increased erythropoiesis in pregnancy. And HbA1c is subjected to pregnancy-specific changes, and it requires trimester-specific levels, which at this point of time, we don't have any. HbA1c is a weak surrogate for impaired glucose metabolism, and it is not suitable for patients with underlying medical illnesses such as renal problem, anemia, or thalassemia. So what approach should we use for early screening? Now we have heard a lot about biomarkers. Yes, biomarkers may allow us to screen and to diagnose early GDM more precisely. However, they are still in research progress. What are the biomarkers being studied so far? PLGF, PEP-A, adiponectin, leptin, glycosylated fibronectin, and many more. So this is a space to watch out for, and we hope there are more evidence emerging soon for us to be able to screen and diagnose GDM as early as possible. Now, what are the doubts when it comes to screening for GDM? Early screening leads to detection of hyperglycemia below threshold level for diagnosis of pre-existing diabetes. So we can call this early GDM. There is limited evidence on threshold level to be used for diagnosis of early GDM because we do not have many studies on that yet. There are still many uncertainties in initiation of treatment upon diagnosis of early GDM. This is a meta-analysis looking into studies being carried out whether to screen and to diagnose early GDM or at a standard screening time. We can see here, early GDM diagnosis was a predictor of adverse maternal and neonatal outcome. There is 2-fold increased risk of preeclampsia in women with early diagnosis of GDM. Higher fasting plasma glucose in early pregnancy, increased risk of adverse pregnancy outcome, is highly predictive of risk factor for GDM, and values above 6% of HbA1c is predictive of GDM. Look at this. Early GDM in high-risk women remains associated with poor pregnancy outcome. HbA1c more than 5.9% in early pregnancy, increased risk of LGA, macrosomia, caesarean section, hypertensive disorder in pregnancy, and many more. But on the other hand, we do have studies to prove it otherwise as well. Implementing early screening for GDM gave no significant difference in neonatal outcome. Lifestyle intervention was not effective in improving obstetrics or metabolic outcomes. Treatment in early pregnancy did not improve maternal or neonatal outcomes significantly. Early GDM screening in obese women did not reduce composite perinatal outcomes. This is another paper looking into early versus late screening and treatment of GDM, and they concluded that there was similar short-term maternal and fetal outcome for early or standard screening and treatment of GDM. And this paper concluded that while a strategy including early measurement of fasting plasma glucose during pregnancy increases the incidence and care of hyperglycemia, but it may not significantly improve pregnancy outcome. Screening for overt diabetes in early pregnancy is necessary. So the keyword here is overt diabetes, not GDM. And screening and treatment of GDM between 24 to 28 weeks is beneficial to reduce adverse pregnancy outcome. Observational studies show conflicting results whether to screen and treat GDM early or not. And in fact, some studies shows despite the treatment, early onset GDM women have more adverse pregnancy complications than late onset. And there was similar short-term obstetric outcome in both groups. Okay, so now let's talk about universal versus risk-based screening. There is increasing trend of GDM universally, mainly due to modern maternal characteristics. We know that our women are embarking on pregnancy later in life now, and a lot of them have underlying comorbid as well. NICE applies selective approach, while FIGO, IAD-PSG, ACOG, RENZOC, and SOGC advocate universal screening. Selective screening may miss out at least 30% of GDM diagnosis. What about one-step or two-step? KKM adopt one-step approach, that is a diagnostic test. The lady will have to be fasted, and fasting blood for plasma glucose will be measured. Subsequently, they'll be given 75-gram oral glucose test, and blood will be drawn 1 hour and 2 hours later. An abnormal reading out of these three will automatically classify the lady as GDM. What about two-step screening? Two-step screening is usually done in the US. It does not require the lady to be fasted in the glucose challenge test. Lady come unfasted, have a 50-gram glucose challenge test, and have their blood drawn 1 hour after that. If it's more than 10.6, automatically they'll be diagnosed as GDM. If it is between 7.2 and 10.6, they will have to undergo another test in another visit, whereby they will have to be fasted and a 3 hours 100-gram GTT would be done. If a fasting more than 5.3, 1 hour more than 10, 2 hours more than 8.6, and 3 hours more than 7.8, any two abnormal results will be diagnosed as GDM. One step is a diagnostic test. Two-step is a screening followed by diagnostic test. One-step test leads to more diagnosis. However, studies have shown that there is no significant differences in terms of composite, maternal, and neonatal outcome. There is more compliance for one-step tests as only a single visit is needed, but the patient has to be fasted. Now we have come to the conclusion of our discussion today. Main points to ponder include: the aim of early screening in first trimester is to exclude pre-existing diabetes using a cutoff of 7 and 11.1 as per non-pregnant population. Screening and diagnosis of GDM should remain at 24 to 28 weeks. Early GDM may have significant implications on maternal and fetal health. However, intervention for patients with impaired GTT in early pregnancy remains controversial. Therefore, we recommend screening and diagnosis at 24 weeks and not early in pregnancy. A diagnosis of GDM in early pregnancy may lead to medicalisation with increased intervention, including caesarean section, induction, and more NICU admission and SGAs. Fasting plasma glucose of 5.2 to 6.9 should not be labeled as GDM. Instead, a dietitian referral and follow-up OGTT at 24 weeks for GDM is advisable. More biomarkers are being studied for their clinical use. The prediction and diagnosis of GDM can be made more precise in the near future. Universal screening should be considered when feasible because 30% of cases may remain undiagnosed using risk-based screening. Thank you.